And now I will bring the presentation up. Now, did I hit screen share? No, I didn't. It's a good thing I talk to myself a lot because you guys can hear what I'm actually saying. My thought process as they, okay, hit that one. Okay, yay, okay, good. We're ready to go now. So my name is Lori McIsaac Bewsher, and I am the owner at Rising Tides Healing Center here in Grand Bay, Westfield. And I've been working in private practice for about 4 years now. I've been primarily using EMDR as my primary modality for about 3 years or so now. Just heard a little bit of feedback, but Jenna can grab anyone who's not muted for me. So I am a certified EMDR therapist, which just means I've done EMDR basic training, and I've become certified through the process of getting additional training and education consultation. And I'm in the process actually of becoming an EMDR consultant in training, so I can provide that same support to others. We have, I think we're up to 4 EMDR therapists on our team here at Rising Tides Healing Center. So it's a pretty important modality in the work that we do in helping people to heal from trauma. The healing center itself is actually a whole building. So our counseling office is part of the center, but we also have additional supports. We have an osteopath in the building. We have foot care, we have Reiki, we have yoga classes. And yeah, we're here to be a community center for hope and healing. So we're always kind of open to new partnerships if somebody feels like a good fit for our center. So the flow of today, just to kind of clarify, some of you might have signed up, not exactly knowing what you were signing up for. This webinar is intended to be just some introductory information. You'll learn a little bit about EMDR, but it's not an EMDR presentation. We're really focusing specifically on early EMDR intervention and how that differs from standard EMDR protocols. And we are also wanting to present a little bit of information about the benefits of an early intervention. And I guess I'll even just start by saying part of the reason why I'm so interested in this approach is because as an EMDR therapist, I work with a lot of people who have experienced trauma, sometimes across their lifetime. Sometimes it's been something that's been with them for, 1, 2, 3 more years. And when I work with people, I sometimes think, oh, if we could have gotten to them a little bit earlier, maybe they wouldn't have had to suffer so long with it. So this presentation is very much focused on the benefits of early EMDR intervention. So we're kind of talking to you as people who may work with people, who may work in places where people are at risk of psychological trauma or injury. It's not to say that this information wouldn't be helpful to you if you're a person in need of support too, but the general flow of the information presented is going to be like, how can we use this? Who is it helpful to? Where can we use early intervention strategies? Because they really don't exist in our part of the world right now. As you'll see throughout the presentation of materials, EMDR, is still fairly new as a psychotherapy approach, but early EMDR intervention is sort of even newer than that. So I think I'll start jumping into the slides before I get too ahead of myself. So this slide is just a brief kind of introduction to EMDR. So actually, I did have a poll I was going to ask before we really get started. I wanted to get some sense of how much do you already know about EMDR, and also get a sense of where you work, what you do, what you're interested in. So I'm just going to share a poll here with you. And when I launch it, you should be able to submit your answers, and then we can all see the response, which is going to be kind of interesting. So you should see 3 questions in front of you. And if you can select your answer, do you see them? Did they pop up? Yep, okay. Okay, and it looks like everybody's had a chance to respond. So I'll end the poll and we can see the results together. So how much do you already know about EMDR? So most people know a little bit. Okay, one person doesn't know very much yet, and another person has some knowledge but would like a little bit more. Do you work with people at risk? Often, yeah, because I think probably most of us do. Often or sometimes would be 90% of respondents. Okay, and what industry do you work in? Healthcare and social services, transportation, and other. Awesome. Okay, that's great for me to know. Thank you. So I'm going to go back to my screen. There. Okay, so since some people know a little bit about EMDR, EMDR is eye movement desensitization and reprocessing. So it is a mouthful of a title, and the person who discovered it, Francine Shapiro, she actually has said if she had her time back, she probably would have named it something different, because it is a bit of a mouthful and it's not just about the eye movements. So she discovered the eye movement when I think she was a PhD student at the time, actually, and she just sort of observed that when she was thinking of a distressing situation, that she noticed that her eyes kind of naturally were darting back and forth. And actually, now that I'm telling you this, you will notice this when I'm in conversations with people and they're kind of bringing something up. There's a natural movement towards fluttering your eyes back and forth when you're recalling disturbing material. So she took this and she's just started studying it. She just thought it was a curiosity. She started applying it. She's worked with veterans. That was the first population that she started working with. And that's kind of where EMDR began. And when you look at the late 1980s, it's still relatively new, but since the 1980s, EMDR as a treatment protocol for PTSD primarily is what it's been used for. But as we've evolved the practice of EMDR, you can pretty much use EMDR in a variety of mental health situations, but we use it a lot for anxiety, depression. You can use it for addictions. You can use it for eating disorders. There's lots of uses for EMDR now, but PTSD is the area that's been most researched and studied to date. So the thing about EMDR and why it's important for the work that we do is that we're focusing on helping the brain to heal from the trauma that it's experienced. So this is somewhat of a departure from other methods of treating trauma, like cognitive behavioral therapy interventions, where we're kind of focusing on thoughts, cognitions. We're trying to change a behavior or an action by talking our way through it. EMDR is very much focused in healing the brain, understanding that our memories, our experiences are stored in our brain. And in order for our brain to heal, we need to help those memories get adapted so that they can be in our brain, but won't cause us so much distress. Because when somebody has PTSD or has been impacted by a trauma, you usually will see things like nightmares, intrusive thoughts, just recycling of memories or experiences. And we can't always talk ourselves out of those, right? And it's not to say that other interventions can't have a positive impact on a person's healing from trauma, but why EMDR really started to gain some traction is because it kind of moved the process along a little more efficiently, and people were getting better results quicker with the use of EMDR. So we're focusing on allowing the brain to naturally do what it wants to do. So the next slide, actually, and that's a picture of me. You'll see my fingers in the air because I'm before COVID, I did probably 90% of my work with the back and forth tracking of the eye movement, which is the way it was originally done. Because of COVID, we've had to be a little bit more creative because we do a lot of our work online now. So the bilateral stimulation, so that tracking back and forth of the eye movement, it can be done as long as it's a bilateral movement. So online, I tend to do a lot of butterfly tapping, and it's just tapping back and forth. People can tap on their legs. You can use headphones. You can use sound. As long as it's a bilateral back and forth stimulus, we can use it in EMDR. So that's why it's not just eye movements. So the AIP model is it's the theory of EMDR. So this is sort of the explanation of why EMDR works. So we have a lovely picture of our brain because that's, the center of where everything gets processed. So the adaptive information processing theory is based on the idea of that when we have an experience, something happens, everything gets filtered through our brain. So most of us know that we have an amygdala, our alarm center when we're exposed to something, startling, unusual, something that requires an action or a response. The amygdala kind of sends out the signal to the rest of the brain that we need to fight, flight, freeze, whatever we need to do for our safety or survival. And once that gets activated, which should happen naturally as our brain kind of goes, oh, I remember a situation like this, or I know how to react to that, we escape from the threat, and then our system settles back down again. For a person who has been exposed to PTSD or has experienced a trauma, there's some stuckness. Some part of the memory gets stuck in the fight, flight, or freeze response. So with the AIP model, with what EMDR is doing is we're taking the traumatic memory or experience, and we're helping it to become unstuck. So I put this quote, it's not my quote, it was in my training from my facilitator, who often said we have 1 foot in the past and 1 foot in the present. So there is the safety of EMDR is that we're not getting lost in the memory. Because if we just go 2 feet into the memory, then you've dissociated, then you've gone into the past trauma, and the healing can't happen in the same way. So it's really important as EMDR therapists that we're keeping the person present in today while they're recalling the traumatic information. So I already talked a little bit about the bilateral stimulation. So what that just means is when the person is recalling the trauma, recalling the experience that has gotten stuck in their brain, we're constantly doing the bilateral stimulation. It's called processing. We as the therapist are guiding the pace of the processing. So if a person is recalling a trauma, we want to go fast, right? We want to kind of get them to some relief as quickly as we can. And we just want to help that brain go where it needs to go with the support of a safety person in the therapist. So that's the AIP model. But the benefit and why we're talking about it here at the beginning of the presentation is with early EMDR intervention, we're preventing things from getting stuck. So as opposed to many of the clients that I would see in my private practice who have PTSD or who have been living with trauma for a longer period of time, their memories have been consolidated. They're in their brain. There's certain stuck points that need some relief, and we kind of got to go back to the beginning of their memories and figure out where it started so we can help get them some relief. With early intervention, the memories haven't consolidated yet. So they're still sort of figuring out where they're, am I safe now? Am I okay now? And if we do this work now, we can prevent the development of PTSD, which is incredible when you think about it. And it's part of why I really have been moving towards more of this early intervention approach, because I want to help people not suffer in the first place, if at all possible. So we're processing. It's actually a therapeutic intervention. We're actually working on the memories, but we're also doing some preventative work by helping the person process their experience before it gets stuck in time. I have a couple of handwritten notes, but I just want to make sure I'm hitting the highlights. I can't see the chat anyway, so if anybody's chatting, we'll have to hold the questions till the end. So this slide is just sort of another little oomph for, why we've got some credibility in the EMDR world to talk about what we're talking about. It's evidence-based treatment. There is a lot of research on basic standard protocol EMDR, how it's used in the field. It's endorsed by many big organizations like the American Psychiatric Association, U.S. Department of Veterans Health, World Health Organization, the International Society of Traumatic Stress Studies, and the U.S. Department of Defense. So I think you'd probably agree with me. That's a pretty glowing endorsement, recommending EMDR as the best or as a best practice for treating PTSD. And we included the photograph of Prince Harry because is there a better endorsement than former royal? Harry has been an advocate for EMDR. He and Oprah Winfrey did a movie on Apple TV. I watched it, The Me You Can't See. And he talked about his own experiences using EMDR in that series and had a lot of success with it. So he was sharing his experiences with the world, which is always helpful to us. So that's sort of EMDR in a nutshell. So I just gave you like, I don't know, 15 minutes worth of content and what we usually take in training over like 30 to 60 hours. But that kind of gives you the rationale for why, how EMDR came to be, how it works. Now we're going to talk a little bit about early EMDR interventions because they're a little bit different. So early EMDR interventions kind of came to be when Francine Shapiro was in California at the time of the earthquake in 1995. And, she really was quite a brilliant woman when you think about it, because she started going, there's something that's not quite right for these people who have had a recent trauma. So what she was doing with veterans who, of course, had been overseas, come home, there had been a period of time of consolidation of the memories. With the recent victims, there wasn't the same response to treatment. So her words around early intervention was typically it's 1 to 3 months, because in that window, that's the window before the memories consolidate. So that's why, we don't have to stick to a calendar, but if we're talking about early intervention, we're typically talking about something in the 1 to 3 month range, but it can be longer. And an example of that would be for somebody who might live in kind of a chronic traumatic situation. So think of somebody who might live in a war zone, somebody who's in a domestic violence relationship where, there's no necessarily end to the trauma. These interventions can still be beneficial to people. I think I'll just keep going on to the next slide because I have a tendency to get ahead of myself. So I'm going to just let some of this sit. Oops. So I've already kind of stated this, I think, but the purpose of early EMDR intervention is to both treat, the PTSD symptoms that might be settling into the person's system, but also to prevent the development of further symptoms down the road. And I just included these couple of points. The National Institute for Health and Clinical Excellence no longer recommends debriefing. So I was trained in critical incident stress debriefing. I feel like it was about 20 years ago, maybe a little bit longer, because I do remember it being sort of a big thing after 9/11. And it's not that debriefing is bad, but the thing that's kind of come up about debriefing, which is more worrisome, is that if you're gathering a group of people who have been exposed to a traumatic event and we bring them together to kind of like talk about what they saw, what they heard, what they experienced. There's benefit in a group sharing experience. The risk is that you can contaminate or cause more trauma to the other people in the room. So if we had all been exposed to the same traumatic situation and, let's say we were all exposed to a shooter, a mass shooting or something had happened. And my experience was, I actually saw the shooter come in and take the first shot, but your experience was you were in the back of the room and you didn't actually witness any of that. By me sharing what I was exposed to, even if you didn't have the memory to begin with, now you're getting the information from me and it starts lumping in with the experiences you've had. So debriefing can have some benefits, but we're starting to move away from that kind of group mass sharing as a way of debriefing or desensitizing the situation. And psychological first aid, again, not a bad intervention. It's still being researched. We just don't have the research or evidence to support that it's getting the results that people actually need. And psychological first aid is often like the supportive counseling, taking care of yourself, the good taking care of each other that we need to do as well. But if we're talking about early intervention, and I'm assuming a lot of you on this call are interested in this because you do work with people or you're responsible for people who are at risk of psychological injury, and we don't always have a lot of time, resource. So we're kind of trying to find what are those best interventions that we can use that can prevent, time, money, person's mental health, person's success in the long run. So there's a little bit of research. I almost said there's a fair bit of research, but the truth is early EMDR intervention is still fairly new in the literature. So I was trained by a group in Florida, and they actually have like an Excel spreadsheet of every study that's kind of been done and studies that are upcoming over the next couple of years. A lot of the work has been done in Europe, so it's not something that we have as much research here in Canada. This is just sort of a little bit of a highlight of the studies that have been done. So in 7 random controlled studies on EMDR early interventions, they've all been done on adults so far, so we don't have a lot of information on the results with children yet. And they were all 1 to 3 sessions, because this is meant to be a brief intervention. This isn't meant to be long-term therapy. This is meant to be done over a brief amount of sessions. And the results of all of those studies in combination was that EMDR early intervention produced a significant decrease in the post-traumatic symptoms, and it was superior to critical incident stress debriefing and supportive counseling when it came to outcomes for people who have been impacted. So this is the first slide on, early EMDR intervention kind of includes a variety of interventions. I'm going to talk to you about 2 specifically that I've been trained in and that I've been using. So the first one is the recent traumatic event or traumatic episode protocol. So this was developed by Ilan Shapiro and Barut Loeb in 2008. And it kind of came from Francine Shapiro's work after the earthquake. So it's kind of evolved from some of the work that she was doing in the early days and other EMDR therapists who have been researching early EMDR intervention. But Ilan and Barut developed this recent traumatic episode protocol. And the important part of this acronym is the episode part, because we had some protocols for the traumatic event, right? If you're in a car accident or there's some type of violence that you witness, we had protocols that would focus on that specific incident, but the changing of the language in the intervention to the episode, because often when somebody is exposed to a trauma, it's not just one moment or one thing. It occurs over a period of time. Even if that period of time is 15 minutes long, there's an episode of things that have happened during that period of time. So R-TEP is an individual intervention. So because it's early, we know that the memories are still fragmented. And so traditional EMDR might not be as effective. So the narrative in the Google scan is sort of the part that makes the recent traumatic episode protocol different from the standard EMDR protocol. And it won't necessarily mean a whole lot to you, but as a therapist, what it means is when the client has been exposed, we're going to let them tell the story. So there's a narrative. They're going to tell the story of what they experienced. But what we're going to do, and this is the processing piece, this is the treatment piece, the Google scan is we're just going to let them run that story. And when they hit a point of disturbance, so that point of disturbance could be when it started. If that's the very first point of disturbance, we're going to process it. So with EMDR, using the bilateral stimulation, we're going to let them take that first piece that causes a distress, and we're going to process it with them so that we can get some relief for that particular moment. Then we're like going to run the reel again. We're just going to let them go to the next point of disturbance. So with traditional EMDR, we don't do it that way because the memories are consolidated. So we're more able to kind of work with specific memories on a network. With the recent events, it's still pretty scattered. So we kind of let us know whenever they hit a point that's disturbing. So it's structured and it's systematic. And I actually would say this about traditional EMDR or standard EMDR as well. There's a comfort for clients in knowing that there's a system that we're working through together. So this is just a tool, it's a protocol, it's an approach. You know, we have scripts, we have a narrative that goes along with this to help people who have been exposed to a trauma. So this is the individual part. So this is the very specific tool that we would use for somebody who's been in that 1 to 3 month window after a recent traumatic event. So this slide, I knew I wouldn't have time to go into all of the research, but I was like, I'll just pull out a couple of the studies that show the results of these interventions. So this was a study looking at interventions, early interventions in an emergency room. So they were actually kind of looking at 2 outcomes. One was post-concussion-like syndrome and one was PTSD. So if you can see in the grid, for the portion of patients who had post-concussion symptoms at the end of a 3-month period. So the first group is the control group. So there was no treatment offered. The second block represents reassurance, which is the usual supportive counseling, healthy habits, taking care of yourself. And the third box represents those who got the early EMDR intervention. So for the post-concussion symptoms on the left-hand side, you can see that for those who got the EMDR treatment, there was a reduction in symptoms. For people with PTSD in figure 2, the results followed a similar pattern. The severity or the number of people who were impacted by PTSD was lower, which might make sense in an emergency room. But you can also see for those folks that received early intervention at the emergency room 3 months after their experience or event, that with early EMDR intervention, they had almost minimal symptoms. So it just kind of is showing the benefit of getting there early, because I can guarantee if we were looking at a figure 3, which was people who got treatment 3 years later, which unfortunately sometimes is the case for people, we'd see benefit with EMDR, but we would see a lot more people impacted just because of the delay in the treatment. So that's, the recent traumatic episode protocol. And then we started moving into group protocol. So this is Elon Shapiro. I've actually had the opportunity to see Elon speak twice in the last year. Thank goodness for technology that allows us to get closer to the people who, create the protocols and can train us in it themselves. So Elon started the EMDR group traumatic episode protocol because he was recognizing that there was a need for something that could help groups more efficiently. So when we were just talking about the individual recent traumatic episode protocol, it works well. We used it in the emergency room. It's been used in a lot of places, but you're still only working with one person at a time. So Elon's thinking was like, when there is an event, a natural disaster, mass casualties, is there something we can do to help people recover more promptly from an episode like that? So it was developed sort of the same principles as the recent traumatic episode protocol and the IGTP, which is just the integrative group treatment protocol, which was sort of a supportive, kind of almost like the reassurance or the supportive counseling options, but it's done with butterfly tapping and hugs. So it's done with some resourcing included with it. He mentioned that it was because of natural disasters, mass shootings. Unfortunately, we're having more and more of those, financial catastrophes. So Elon actually practices out of Israel, and he actually has a really good video I kind of looked for in the public domain, but it wasn't available, about some of the work that he has done with Syrian refugees in Turkish camps and using the GTAP protocol, which is really kind of cool because language wasn't as much of a barrier, and you'll see why when I show you how it's done. So they really got some good results going with refugees there. So the principles of GTAP, so the group traumatic episode principles, is that we can process individual trauma more deeply in a group setting. So it just allows us to treat a larger number of people and get deeper. So it's not just psychoeducation. It's not just kind of telling people where to get their resources or their help. It's actually doing the processing work in a group setting. It's confidential and there's no negative material that's shared. So this is the part that I really think would be helpful to a lot of places and organizations, is that when you're doing a group traumatic event, you can gather all the people that were impacted, but nobody's sharing their stories of what they witnessed or what they saw. It's all being done individually in their own individual processing. There is positive sharing, so there's opportunities to share a positive experience, but there's no sharing of the negative materials. And it's actually why you can do GTAP with a group of people who don't share the same trauma. It's typically going to be done with people who've been exposed to the same thing, but you could do a group protocol with people who have different traumas because they're processing individually anyway. The group protocol and the recent event protocol both teach stabilization and self-management. So what that means is, because it's a preventative tool, as we're helping the person process the traumatic material that they experienced, we're also teaching them stabilization skills and self-management for the future. So I suspect that's probably a big part of the reason why the numbers post-treatment are so positive, because it's not just doing the therapy work in the moment, it's actually teaching them how to manage those moments of distress if they come up afterwards. So yep, GTAP addresses the fragmented multi-target nature of trauma memories, because with most trauma memories, it's not just one thing that's traumatic. There can be many points of trauma. So the GTAP protocol gives the person the opportunity to work through as many as they need to. But I'm going to show you how we do it here in a second. And it is adaptable and versatile. So like I said, with language, we use a worksheet with people when we're doing the GTAP protocol. So it's very versatile and can be adapted to a lot of different language, ability, comfort. So this was just the little bit of statistics I pulled from the research. And this was just evaluating the EMDR group traumatic episode protocol with refugees. So it wasn't the video that I was speaking about, but it included 2 sessions of EMDR GTAP with 18 Arabic speaking refugees from Syria and Iraq who had come to Germany during the previous 5 months and assigned to treatment or not, or delayed to receive treatment on a wait list. So I think you can see it, but these 2 figures are representing the pre and the post questionnaire. So they gave everybody a questionnaire at the start of treatment to see where their baseline was, and then they repeated them. I'm not sure what space of time they repeated them, but usually it's at least a week. You want to have some time to see the benefit of the intervention. So in the first box, the tool that they used was the Impact of Event Scale Revised, and the second was the BDI, which is the Beck Depression Inventory. So if you look in the first block and you kind of look at the control group versus the GTAP group, you'll see that there really wasn't a significant change in the control group pre and post-vention on the IESR. But if you look at the GTAP, you can see there was a dramatic, about halfway probably, a decline in those symptoms. And again, on the BDI, you'll see that actually in the control group, it actually looks like there was a little increase in distress post-vention. And in GTAP, we again see a reduction of about half in terms of symptoms. So yeah, that study was 2017. And I think the one I showed you for the recent traumatic episode protocol was 2018. So I mean, still pretty recent studies that are coming out of this. So I'm going to keep an eye on time. Yep, okay, I'm okay. So the GTAP process, just to tell you a little bit about how it would work, and if this is something that you might be interested in having, knowing a little bit more about bringing into your workplaces, or just kind of wanting to know a little bit more, there is an intake and screening process. Like any kind of therapeutic intervention, we can't sit here and say this is going to work for 100% of the people 100% of the time. So we are kind of screening for like stability. If somebody, had a traumatic event at work, they witnessed, an accident, and they're also going through, a divorce, loss of a parent, multi-stressed, they're probably going to have a harder time being able to engage in a group like this. So we would do the intake and screening. We do use data like the BDI and other screening tools to kind of help us measure where people are at before they begin the intervention. So we do the testing before and after, just like we do with EMDR too, to monitor how people are responding to the treatment. So not all participants are going to be appropriate. And if somebody's not appropriate for GTAP, they're probably appropriate for R-TEP. So it just means the group may not be suitable for them, but it doesn't mean that they would be excluded from being appropriate for treatment. And we'll get into the colored workshop sheets. So this is actually the GTAP worksheet, and it's been kind of modified and changed over time. And I'm going to walk you through each phase a little bit closer. But what I want you to notice on this first initial screen is just sort of how it's laid out. So the worksheet is the design of the treatment, and the person who's participating can take this home at the end of their session because there's some good information for them to have here as well. But what I'm going to call, what I'd call your attention to first is I just kind of want you to notice how on the bottom, the trauma episode, so there's the date today and there's the date then, and the trauma episode kind of runs across the bottom of the whole sheet. And that is because we're trying to contain the whole traumatic episode on the sheet. So there's today, where we are today, because the episode has continued right up until today and we're getting some treatment, and the date that it started. So there's just a visual cueing of this is the episode and this is what we're going to work on. So every participant would be provided with a sheet. So for some people, a single session maybe is sufficient. You know, some participants may be able to go through the group process and get that anything that could have gotten stuck gets moved, gets processed. They feel the support of the group, they're good. The group is voluntary, so that just means it's therapy. It would never be ideal for people to feel like they have to participate in something. And when we deliver GTAP, we would do it with 2 facilitators. So we can have one facilitator who's leading the exercise and activity, and we can have another person who's kind of checking in on people and seeing if they're okay. We're sharing positive materials, so there's no sharing of the negative information like we already explained. So I'll explain that a little bit more as we go through it. And we can do it virtually, like everything else, you know, even things we didn't think we could do virtually, we can do virtually. And so I was trained in this modality virtually, so I've experienced it as a virtual participant. I mean, personally, I still think I prefer to be with a group for the energy and the connection that you get when you're with a group of people. Oops, I spilled my water. But it is valuable to know that we can have the opportunity to share this with people who can't gather for whatever reason. And we say it's approximately 2 hours, but of course it'll sort of depend on the group and their needs. And yeah, I didn't mention it. We said a single session may be sufficient. Like I said, it's a brief intervention. It's an early intervention. It's not meant to go on forever, but you might find, you know, the facilitators might decide at the end if participants haven't gotten the relief that we would have expected, a second session may be appropriate too. If we've done 2 sessions or even 3 sessions and people are still struggling, I think it would just be an indicator that we need to do a different type of intervention to support them. Okay, so I won't take terribly long to go through this, but I just wanted to give you the idea of what happens. So if you remember the big worksheet, it goes in a flow. So step 1 is in the bottom right-hand corner of the worksheet. And this is a resource or a strengthening exercise for participants. So we're starting with something that's resource building. So it can be done with the large group or it can be done as a standalone. And that just means for some groups, we might just want to spend 1 hour working on this stabilizing resource. If that's what the group needs first, we can then go on to the rest of the protocol, or we might decide this is sufficient for one chunk of the work. So it focuses on the safety of the present day. So you can see the bracelets. I actually have my bracelet on. I have been wearing one ever since I kind of did the training, and we got some bracelets here. So what we would do is provide the participants with a bracelet. So you'll see the words fire, water, air, and earth. It teaches the 4 elements. So it's really just a grounding tool. And the reason why we use bracelets is because we want to teach the participants, we want them to associate this exercise with a physical reminder. So we would walk the participants through the grounding exercise, getting them to draw on the 4 elements. So like earth, grounding to the earth, to your feet underneath you, air through your breath, water is kind of making saliva, as you've already seen from me a couple of times. When you talk a lot, when you're a little nervous, you start getting dry in your mouth. So we want to create that saliva. And fire is lighting up our imagination. So being able to create some calmness through our imagination. So what we would do is lead the participants in, walking through the 4 elements, giving them their bracelet so they can use this as a reminder moving forward. So if I'm going about my day and I'm feeling anxious or stressed and I look at my bracelet, it's a physical reminder for me to check in with myself. And 100% of the time when I teach this activity to clients, if their level of distress is like an 8 out of 10 when they notice it and we walk ourselves through it, they always reduce in distress. It's just one of those tools that has a very good outcome for helping people become more grounded. So step 1, we just get them to, they can draw a picture of their safe place. They could, use a couple of words to represent a place where they feel calm and safe. The nice thing about the GTAP protocol is it's designed to be whatever people need, right? Some people are really creative, can draw elaborate drawings really quickly. Some people can't draw stick figures. They don't have to. It's just their reminder of what a safe place would be for them, and having the 4 elements as a guide throughout the exercise. So that's sort of step 1, is setting that up. Step 2 is the beginning of the difficult time. So like I said, a traumatic event doesn't always just have a single moment. It has an episode. So what we're getting people to do in step 2 is just to kind of think about the date that it started and writing it down. And again, just kind of drawing a picture, a few words, something that indicates to them when the difficult time began. So we're starting to get people to activate the memory. So this is where we're starting to move into a little bit of the trauma processing by getting the client to start thinking about, okay, what was the first part of this memory? So the little circle in the top that says 0 to 10, we just get them to make a notation of, on a scale of 0 to 10, how upsetting is this memory to me right now? And they mark that number in the box so that they can see as we move around the sheet how the treatment is impacting them. So step 3, we go upwards on the sheet. And so we've just started kind of opening up some of the trauma memory of the episode. Step 3, we're going to add another resource. So this is just another opportunity to support the resilience of the participant. So it draws from a past strength or resource. So it connects to a memory when they felt good about themselves. And this can be about anything. And in the training that I did, participants are invited to share. So I said there's no sharing of negative material, but there is opportunities to share positive material. So when people talk about, what is something that they felt really good about, you often hear about like graduating, having children, getting married, vacations, just really happy times in their life. And so they draw their picture, mark their words, and they can share with each other. Like, this was something that made me feel really good about myself, because it's in there, right? And you probably know this if you work with people, sometimes when you've been impacted by a trauma, it's hard to remember the good stuff. So we're trying to pull out a little bit of the good stuff at the same time that we're working through the traumatic memories. So step 4, we kind of pop over to the right side of the sheet. And this is, if you're trained in EMDR, you'll kind of recognize the familiarity of this. This is our positive belief about ourselves. So we haven't worked through the traumatic memory yet, but this is where we're kind of getting the participant to start thinking about, what is it that you really want to feel? Because when you've been exposed to a trauma, you usually feel the opposite of these. Like, I don't feel safe. I don't want to leave my house. I'm too afraid. I can't get over it. So what do you want to believe? Well, what I want to believe is I'm safe now, or that I can get help if I need it, that this is over, that I can cope with it. So we're just kind of opening up the idea, the network. This, if you remember, when we started talking about the brain and how we're trying to help the brain naturally heal and adapt and store the information where it belongs, this is where we're starting to show the brain where it needs to get to. So that's why we do it at this phase, because we're just starting to get the participant to think about it. So step 5 is the trauma reprocessing. So this is kind of the meat and potatoes of the group traumatic episode protocol. So what we do at this point, because we have a group of people who are processing in the recent traumatic episode protocol, do you remember we'd talk about the Google scan, the narrative scan, where the client would talk about what they experienced? We still do the Google scan in the group protocol. We just don't say it out loud. So I don't know if you're going to be able to see this, but hang on. I have my sheets here. So we have these sheets printed out on 11 by 17. So what actually happens, okay, bear with me because I'm going to see if I can tilt my screen so you guys can see my sheet. It might not be perfect. But the Google scan is, we're going to tap on today's date and we're going to go to the date when this began. So the Google scan is done by tapping. So when we're tapping back and forth on the worksheet, we're asking the participants to have their eyes follow their hands back and forth, back and forth. So we're just mimicking that bilateral stimulation that Francine originally discovered. And that is just to help the client. That bilateral gives them a little bit of distance from the traumatic memory, but it's also starting to walk them through what they experienced. So the Google scan, we're going to get them to stop. As soon as they hit a point of distress, we're going to get them to stop. And if you look at the bottom for pod 1, so pod is point of distress, we're just going to get them to make a notation in the upper box of what their distress level is on that scale of 0 to 10. So okay, doing my processing, I hit my first point, 10 out of 10. So I'm going to write, okay, so this was the moment where I started feeling distress. I write my 10 in my pod. So then we go to processing it. And I hope my screen here isn't too distracting. But what the difference is when we start to process it. So we identified our memory in pod 1. Then we're going to start processing from pod 1, but we're going to be tapping back to today's date. And again, it's just a visual representation of the safety of today, because this is where we are today. This is the distress we're experiencing. So instead of doing the whole episode like we were when we were trying to find the points of disturbance, now we're working on it. So this is where we're doing processing work, and silently, the person is going through the traumatic material. They're tapping back and forth. They're just kind of like an EMDR, how we guide people, don't search, don't fight, just notice what comes up naturally. You don't have to go looking for it. And we just do this 3 times. So we repeat that a few times. We go back and forth. Then we come back and we say, okay, what is your level of distress now when you think about it? Because you may or may not know this, but this is exposure, right? The more time you spend working on traumatic material, it will naturally desensitize, especially when you're getting the support in the safety of a group. You've got some resources developed and you're being guided through this process. So we're just helping the person desensitize as much as they can. So we're always using that scale of 0 to 10 to measure distress. And we just keep repeating that. So the first pod on the bottom, we'll do that 3 times. And then we'll just kind of leave it. We'll go back and do another Google scan. We'll find the next point of distress. We'll work on that. So this is the part where, there's a little bit of flexibility. Do we need to work on more pods? Do we need another episode? Kind of depends on what the participants have experienced. So I think I hit all the highlights on that one. And then step 6 is when we're installing the positive belief now that the distress is decreased. So what we're doing now is taking a reading of the whole episode. So we did that way back in the beginning. Now we're looking at, now that we've processed a few of the points of distress, what is your distress level now, and rating it on a scale of 0 to 10. So, and we also want to start installing the positive belief. So what do you want to believe about yourself? Okay, well, I want to believe I'm safe now and that I can cope with this. And this is when we're going to start installing or doing some tapping to get that strengthened. So we as facilitators would be looking at these numbers to see if the distress has come down at all. We would expect for many people that the distress would come down naturally, but if somebody has a number that's higher than like 5, 6 out of 10, we probably want to have a quicker look at that person and see if they're doing okay. And then step 7 is just sort of the closure. Do we need to do another session? You can close with the 4 elements again. It's a wonderful grounding tool that the participants have already learned how to do. They have their bracelets on. It's just a reinforcement of I can be okay again, so that it's contained at the end of the session. And like I said, some people still may require individual therapy at the end of that intervention. So we would be looking at that to see if somebody needs some extra help with processing what they were exposed. And this is the conclusion. These were just a couple of statistics that, we pulled out as we were preparing the presentation and thinking about, we work with a lot of first responders as EMDR therapists. So some of our information came from here. First responders are twice as likely to suffer from PTSD as the general population. So what that should tell us is we need to do more things to support first responders to avoid the onset of PTSD symptoms. And first responders, I know we typically think, paramedic, police, fire, and they are first responders, but, the PTSD and trauma that we're starting to see is healthcare, education. I don't think there's any industry that's probably exempt from having the risk of trauma. Women are more likely than men to develop PTSD, and out of 2.5 million adult Canadians, 70,000 first responders will suffer from PTSD in their lifetime. So this isn't small, this isn't something that only happens to a very small portion of our population. It's something that is worth considering how we're going to help take better care of the people that we work with. So And that's it. So this is our contact information. After the webinar, you will get an email that will tell you how to get in touch with us. If what I presented to you today is something that you'd like to learn a little bit more about, or you would like some information about how to, integrate it or have this service available to your workplace, you can always contact us to arrange a time to talk personally about your needs. And what I will do is I'll stop the share, and I assume everybody had time to get the information. Now we're in the day and age of you can just Google it anyway, or go on Facebook or LinkedIn, Instagram, you'll find us everywhere. And I can see if there is any questions. And so you can unmute yourself if you want to speak, or you can drop a message in the chat. I'll just give it a couple of minutes to see if anyone has anything.
Couple other examples of calibers of folks who might benefit from this too are group home workers and funeral directors.
Absolutely. Yep, that is very, very true. We see a wide variety of people that are impacted, and yeah, that's good to know. And that's kind of why even our marketing was towards like, people know what they need. I often work with first responders who are like, man, I wish I would have known, or I wish we could have gotten this type of intervention sooner. And actually some of my clients are my biggest supporters, because they're like, I tell everybody about this. I tell everybody about what you do. But we got to get it out there to the people. Group home workers, absolutely, we see are being very impacted by what they're exposed to. And yes, funeral home directors too. Thank you for that.
I have a question about the size of the group.
Yep.
How, is there an optimal size, and is there a space when there's too many people?
Yeah, they typically say like 10 to 15 is probably a good ratio for like one facilitator and one, person going around and checking in on it. But I think because of the emergent nature, like, I guess I just think if we had a disaster here, like a train derailment or something where there was a number of people that were potentially impacted, I think the creators of this protocol would say you do what you can with what you got to help as many people as you can. But I think ideally, we probably wouldn't be looking at like 100 people. We'd be looking at probably doing more groups with smaller people, especially if they're unknown to us. You know what I mean? You don't have a great sense. I mean, you're going to do some screening if possible. But again, like the group that trained us, actually, they were part of the Florida condominium collapse, the Pulse nightclub shooting, because they were in Florida. And in those situations, you don't have time. You don't have time to do all the screening and get a little bit of history. You're just trying to intervene as promptly as you can. So I think it does depend, but there is an ideal number that I think I would prefer.
So would an organization ever, even if they didn't have something traumatic, is this something that they would initiate as part of a wellness initiative?
They could, especially if they, like, all of us have something that we've experienced, right? And even in our training, obviously they're training a bunch of therapists, but we're getting, the practice of being a client participant. We all kind of came up with our own thing to work on. So I think you could bring it in as a wellness tool just to kind of introduce people to it, but I don't think you'd get the same kind of result or benefit as if you're processing a traumatic event. Yeah.
Cute.
Yeah. Absolutely. Thank you, Barb. And I see a couple of questions in the chat. Is EMDR ever offered for those without benefits? Yeah, that one is tricky. And I would say not familiar. Every EMDR therapist that I am aware of is working in a private practice setting here. We in the Maritimes tend to be a little bit further behind other places. I think actually you might get some EMDR therapists trained in the community setting, like community mental health. But typically, I would say right now it's mostly accessible to people with benefits or people with an employer that have the means to support their employees through it. And are you seeing workplaces adopting a direct referral to this type of treatment, either here in New Brunswick or outside of New Brunswick? Yeah, it doesn't require a direct referral. Okay, wait, I got to make sure I'm understanding this correctly. Are you seeing workplaces adopting a direct referral? Yeah. So In my experience so far, the groups that are offering the group traumatic event protocol tend to be people who work in natural crisis, disaster relief. So it's almost become more of an emergency response. The actual bringing it to workplaces is sort of something that I wanted to do. So I don't have the answer on what anybody else is doing, but I think it's because I sit here and work with so many people who have been impacted by a workplace trauma that I go, well, goodness, if we could bring this to the workplaces earlier, then they could all prevent a lot of time and suffering. So it is used in workplaces, but I don't actually have a lot of information about how often it's being used, but it's also because it's so new. It's still sort of gaining some traction. So thank you for your comments, Cynthia. I'm glad you found it valuable. And I see Leanne has her hand raised, and I'm not sure how to do anything with that, but please jump in, Leanne.
Hi, yes. Can you hear me okay?
Yep.
Okay, perfect. So I'm in private practice, but I'm also part of a school system as well. So I know you said that it's not something that has a lot of research to support, like in the way of just in reference to working with children.
Yeah.
But I am wondering, like, are you aware of any schools who are doing this with children? And is it something that we could still do, but there's just not the support to back it up?
Yeah, it's a good question. And I really do think the reason why there's not a lot of research to support it is it just hasn't been done yet. I don't think it's that it could be detrimental to children. It's just that the research isn't there. However, in the research, because I was doing my reading before I did the presentation, the caution was just kind of, because we don't have the evidence, if you are using the protocol with children, just, to be cognizant of, we don't have that information yet. However, I will say I saw Elon speak just like a month or two ago, and there is a training coming out. I can't remember her name. It will come to me as soon as I end the presentation. And she is adapting the protocol and getting ready to launch a whole workshop training series for EMDR therapists to use this protocol with children. So I do think it's coming. It just doesn't exist yet. If I remember her name, I'll email it to you because it's going to come to me. It's on the tip of my tongue. And actually these worksheets, like the one I have is an adult sheet. There is a child's version. So somebody is using it with children. I just don't think we have the information out there yet. It's kind of neat actually to be part of something that is sort of cutting edge, just kind of getting out of the gate and like really just starting to take off, and the research is starting to build behind it. I was going to say something else about kids. What was it? No, maybe that was my last thought, is that Elon's video, when I talked about him doing the work with Syrian refugees in Turkey, there was children participating in that group. So I think the work is being done. We don't have a lot to pull from. Yeah, it's cool.
Awesome. Thank you.
It would work really well with kids. I think
they would love it.
Yeah, I do too. And kids, like many adults, actually, there's something that's less intimidating about using a worksheet, right? Like, it's not like going to therapy. What are they going to ask me? What do I have to say? I'm going to be in the spotlight. It's much more about like being contained in their own little space. Thank you.
Yes, thank you.
Okay. All right. And I think that's all the questions I see and all the hands. And actually, it's like 3:02. I never nail the timing that perfectly. So if there isn't any other questions, I just really thank you for your participation and attendance. Like, honestly, I was overwhelmed to see how many people actually signed up and were interested in learning a little bit more about this. So it's really exciting to be part of. And please reach out if there's anything else we can ever do for you. Oh, one more hand. Cynthia stuck her hand up real quick. Go ahead, Cynthia.
Nope, I was just clapping.
Oh, see, that's
just a clap.
Thank you. See, I'm not used to using all the fancy tools on Zoom. Awesome.
That's okay. Great job. Thank you.
All right. Thank you all.
Bye.
Bye-bye.